My name is Attilio, as Elisa has said. I am from Monash Health. We're formerly called Southern Health. We have 24 chairs across the southeastern suburbs, across 7 different sites. I'm here to present on improving access to oral health services for SRS residents. Over the last few years, I've developed quite an interest in this area. It's not my only interest. I also have interest in playing golf, where I should be today, and also have an interest in drinking red wine, and I certainly could do with a glass right now to steady my nerves. But with my director in the audience giving me a bit of a glare, I better move on and keep to the topic that's on the agenda today. I'm certainly not an expert in this area, but I have spent a lot of time with SRS residents over the last few years. Before I started working in this area, I really didn't know what an SRS was, and so there might be some people here in the audience that are a little bit unfamiliar with what an SRS is, but it stands for Supported Residential Services, and what they do is they provide accommodation and support for people who need support in everyday life. They are privately owned, but they are funded and monitored by the Department of Health. There are approximately 160 SRS facilities that are registered with the Department of Health, and there's 10 that are within our Monash Health catchment area. And within those 10 facilities, there's approximately 350 residents living in those 10 facilities. I'll just show you a few pictures of what they look like in our area. I think there's 3 here that I've taken pictures of. And as you can see from these pictures, they are nestled within the suburbs. They look like a typical house, and you wouldn't know that they are an SRS facility. Before I started working in this area, I would have driven, and I live locally, I would have driven past these places without knowing what they were. So they are just nestled within your typical suburban areas, hence the name Supported Residential Services. Some of them are not so nice. Some are nice, some are not so nice. This is one of the nicer ones that is fairly local to me. It's quite spacious inside and out. It's quite cosy inside. This one's got an open fireplace. It's got very spacious gardens. It's great for the residents, this sort of, this environment. A lot of them don't like to venture outside their residence. So at least here they've got a bit of a garden. They can walk out and get some fresh air. Most of you will be aware that the group is of a very low socio-economic group. They've been identified at a very high risk of oral disease. And when I first started screening these patients, this would be a typical mouth of about half the residents that I would go and see would have a mouth like this. And the access to dental care has been very low over the years. The majority of them have very poor oral health due to smoking, medications, and poor oral hygiene practice. Transport to and from dental clinics has always been difficult. A significant percentage of them have mental health issues or alcohol and drug problems. Now, my involvement with SRS clients started with a project that was funded by DHSV in 2001. We received some money to start our involvement in SRS clients. What we did was we recruited a MAHA worker, which stands for a medical and allied health worker, access worker, which is a lot easier MAHA is a lot easier to say than that. So together with a MAHA worker, a dentist, a dental assistant, and some admin support, we formed our SRS oral health team. And here's a picture of a couple of my team, very happy lot. they make it a lot easy. They make it very easy for me when I'm out screening the clients. Before we got started, we sort of sat together and outlined our objectives. These included, improving the client's oral health knowledge, increasing the attendance to dental clinics, improving the oral health for SRS clients, engaging the SRS staff and proprietors, and arranging a regular and systematic appointment system. And hopefully within the course of the next 10-15 minutes, I'll be able to demonstrate how we met these objectives and others that we had. So not only did we want to screen the SRS residents, we also wanted to address their lack of education and provide them with moral and physical support and transport to the dental clinics for treatment. Now, initially when we got started, we had trouble sort of engaging the clients. A lot of them, as I said, had mental health issues, and we would arrive to the facility and they wouldn't come out of their rooms. We were sort of we felt like we were wasting our times. We would arrive there, we had all our kit, we had all our staff, and we were only screening a handful of residents. And it was a bit frustrating at the beginning, but we sat down and we had to rethink about our approach, and we came up with the idea of engaging or asking the MAHA worker to promote our visits. So a week or two prior to us arriving for the screening, our MAHA worker would attend the residents, the facility, and just speak to the residents, speak to the proprietor, put up some posters, and just to try and promote that we were coming and that we were going to provide some oral health kits and so forth. And that really helped. That really helped engage the clients and made it a far more successful sort of visit. We were also fortunate that the MAHA worker that we recruited was well known to the residents already, and that made a huge difference in engaging this client group. Okay, excuse me. She also helped engage the proprietors, and she also helped us develop a rapport with the proprietors and the staff, and that was a way of just addressing the overall issue at hand. Basically, she did all the groundwork for us, including coaxing residents out of their bedrooms, because again, a lot of them just had issues coming out when there were strange people at their facility. If she couldn't coax them out of their bedroom, she would arrange for me to go and screen them in the bedrooms, which was quite interesting at times. I just didn't know what to expect, but we did everything we could to try and engage as many of the clients as we could while we were at the facility. Our screening process was quite simple. As already mentioned, we spent a bit of time promoting our visit beforehand. It was just a very simple oral health examination that I would provide, just using a portable light, a mouth mirror, and off we went. My dental assistant would chart, but it was just a very simple chart, and take some notes. And the main aim for me was to identify their treatment needs and to identify the urgency of their treatment. So it was like I would go ahead and prioritise them while I was screening them. And yeah, certainly after the first couple of screenings, it became quite evident that the majority of the residents had very, very poor oral conditions and poor oral health, and many had not seen a dentist or had any dental care for many years, 10 years plus in some cases. So after my examination, I would then ask the resident to spend some time with my dental assistant, and she would spend time just doing some oral health promotion, providing some oral hygiene instructions, and we would also have discussions on diet and smoking, and then we would also provide them with an oral health kit tailored to their needs. And you know, they love this. The residents, a lot of them, we found just couldn't afford, you know, a toothbrush or toothpaste and floss and things like that. So they really look forward to receiving those sort of things. And so we could see the value of our visits. It was quite, yeah, very beneficial. We would also spend some time with the proprietors and the staff, having discussions over the food they were providing for the clients. And in some cases, we're also, you know, just speaking to the proprietors regarding swapping their Coke dispensing machines at the facilities for a water fountain. You know, it was just amazing to see, you know, Coke dispensing machines at places like that, which just didn't help at all, didn't help our cause at all. And you know, as I said, there's some good places, there's some pretty sad places, and in some of the sad places you just see the residents, they're all outside smoking, they've got a bowl of Coke, sitting with that, swigging on that cigarette, and that's how they spent most of their day. And yeah, so that's, again, I'm just trying to give you my perspective of how I saw things at these places. So the screening was one component, but we follow that through with treatment as well. We thought, you know, that's what we wanted to do. We wanted to make sure we could treat these clients, because a lot of them had not received treatment for many years. And so all our dental treatment was provided back at our clinics. What we would do, we would block 3 clinics per day to see the SRS clients. So roughly each day we were seeing 3 to 4 residents per day. While I was screening, I was also sort of trying to identify which of the clients were a bit independent or had a family member that could actually take them to the clinic. I would then encourage them or explain to them that they're a priority group, they wouldn't have to wait on a waiting list, that they were fee exempt, and if they could get there on their own or with a family member, they would be seen a lot easier. But that would be only about 10 to 20% of the clients that we would screen. So the majority of them that needed treatment, this is where the MAHA worker, you know, came into play again. And she would make all the appointments, she would provide the transport to and from the clinic, she would support them at the clinic, in the waiting room, and she would, after taking them back to the facility, she would then also you know, go through all the post-operative instructions that I had given them. So just to reinforce what happened in the clinic once they're back in the facility. With the appointments, we found that the middle of the day suited the clients best. They're certainly not morning persons, people. And same with the screenings, we didn't ever want to go too early because most of the residents just laid in bed early mornings. So yeah, early morning appointments. We also worked around their meal breaks. That was a big part of their day, having their meal. So we certainly didn't want to interfere with their lunch, and so we certainly worked around that, and that certainly improved their compliance and their attendance to our clinics. Also, what we tried to do, and this happened most of the time, was the treatment would be provided by the screening dentist. Myself, I had a couple of other senior dentists that I work with at Monash Health who also have been involved in the screening. They would then treat the patients themselves, and if we couldn't be available, then we would at least have the screening dental assistant available just to build on that rapport we had developed at the facilities, and that just helped reduce the anxiety of this group and just made the compliance far better. Yeah, back in the clinics, we also try to make it a bit of fun. You know, the residents really, they don't get out a lot. So when they did come to the clinic, we just tried to, just to add a bit made it a bit extra fun for them, and for a lot of the residents, it was a bit of an excursion for them to be picked up, even though they were coming to the dentist. It was just a bit of fun, and it was just a weekly excursion that a few of them had. And by the end of it, I had a few of them, once the treatment was completed, they actually cried. They cried because they were sad that they weren't going to be coming back for a while. And that was, it touched the heart a bit. Yeah, as I said, a lot of them don't get out much, but look, we certainly have been making quite a difference. Now, I do have to show you some figures. These are the figures from our 2011 project. We screened 141 residents. As you can see, most of the residents required treatment. You can also see that most of those that required treatment were treated, and it shows that the residents were certainly starting to use our services a lot more. So not only were we improving their oral health, we were, I think, having an effect on their general health and their overall self-esteem. And we received some feedback from the proprietors who, basically told us that, after the dental treatment was completed, they were, the residents were a lot happier. They were a lot happier, and that just improved their overall sort of morale back at the facility. Also, on the completion of the project, a sample of the residents were randomly surveyed on their experience. Now, I wasn't involved in this survey, so I'm not sure if they were bribed with a bowl of Coke or a packet of cigarettes, but 100% of the survey respondents were very happy with their treatment. They were maintaining their oral hygiene and had improved oral conditions since seeing a dentist. So in saying all that, I think, I'm sure that this project was a very successful project, and it sort of was the instigator for us to continue our work in this area. We believe we met all our objectives, and since this project we have received additional funding from the Department of Health to continue working with these residents. And in the past 2 years we've continued to attend the facilities, screen the clients, and again identify the ones that need treatment, and we've continued our good work in this area. And our rapport just continues to develop. Each time we go to a facility, it just gets easier and easier, and the clients are far more welcoming. The staff really enjoy us coming, and it's a very positive experience. We are now starting to attend facilities for the third time within a 2 to 3 year period, and we're certainly referring far less now for treatment. They're mainly just the new clients that need to be referred for treatment. So we've certainly developed some really good relationships with the residents, the staff and the proprietors. I even get invited to their Christmas functions now. Oh, I'll just go back. Okay. So in the last few years too, we've also developed a partnership with some other organisations. We are now working with Peninsula Health and Gippsland Health in looking at all the facilities within our catchment area. We're sharing ideas, and we're always looking at what more we can do to offer our SRS residents. We also have linked with mental health organisations such as IRMA and My Health in order to tap in for a bit more assistance and support, especially with transport. It's just it's a lot to ask one person, our MAHA worker, and she's not meant to be working full time with us. She's only part time, and she does a lot of work for us, and it's probably unsustainable. So that's where we're trying to tap into other organisations to get additional support. And and hopefully that's what we're looking for. Going from that first picture to something like that. And hopefully in 5 years' time, if I'm still working at Monash Health, and if I'm still working on this project, we'll be not having to refer too many clients at all. So thank you very much.
Thank you very much. I've been asked today to talk about the process, I suppose, that I've made from that very, very nervous young person going out in my first day of the job up at Bendigo, meeting some Sue, you may have know a few, and to now finding myself presenting to, my goodness, my colleagues. So yeah, that it's just a little bit about that journey. It has a pretty fancy title, Integrated Health Promotion in Public Facilities. I'm hoping I'll stick to that topic. So in the beginning, back in the old dental van years, I could not find a dental van picture anywhere. This one is actually a dental van that's being shipped off to Fiji or somewhere like that, but and I must admit that isn't me, that picture as well. So, but back in doing my associate diploma of applied science at St Kilda Road and finishing that in 89-90, then went up to the next decade spending time in the Bendigo area, as well as then down in the Mornington Peninsula. Had a few years off where I had some children, had 2 kids, and then in 2004, to my surprise, found myself back being a dental therapist. And I think Anne may have got that phone call, she's here today, when I was surprised to say that you would have me back as a dental therapist. So yeah, clocking up nearly 20 years, it just is amazing. So back then, in those days, it was health promotion just in your vans. You talk to your kids, and I always wanted to tell them, and always wanted those grade 6 kids to go out knowing how to floss their teeth. I probably might have been one of the, I wasn't the only one saying that, but I felt really important that they had to know themselves. The classroom lessons that in the early 90s, I really liked them. I thought they got me out of the van and got to meet those children in their environment rather than just on a one-to-one basis. According to the evidence-based oral health promotion resource, this downstream model of health promotion was just ineffective. But you know what? I just think we just didn't document it. We didn't research, we didn't evaluate it. So I think there was a lot of good things that happened back then that we just didn't know how to record and be able to use. So much of that I think we've lost, but that's the way it is. Some of the other barriers I think to the health promotion in this setting were the output demands and the expectations of targets, and that's money. That's all comes down to money, and that was just the way it was. Around 2010, I came into the jargon of health promotion. Oh my goodness! If anyone has done any reading into this, there's so many words there. You just think, what does all that mean? And it's a whole new language. It blew my mind. The first part, as Southern Health, that was who we were before. We've now become Monash Health, but they gave me the opportunity, along with about, I think there was 4 dental assistants and myself as a clinician, to take up the training. And it first began as an online training, just on the computer, lots of reading and a lot of these words, these just strange words. Followed up by a 5-day training course that was run through Monash University. And that was amazing because all of a sudden, it was still very dentally focused, but that 5-day course then went, wow, there's people working with refugees, there's people who are in all these different fields who have got no clinical, there were no dental people at all. So here we were just starting to expand into all this health promotion isn't just something that I do myself. It's all these other connections. And that was really a valuable thing. But coming out of that 5-day thing, the big thing that came out was evaluation. And I think that I think that Andrea spoke earlier, really clearly says that. Her whole focus is to get what we're doing every day, all those good things that we do in our clinical side, onto paper and into money terms for funding. And that's simply what it is, or boils down to, is trying to get what we do physically into numbers for her to manipulate and get some money for. Evaluate. So that's what I learned at that particular time. In the next years, it was basically still doing chairside. I was working part-time. But I still had that sort of burn, I suppose, from being at a course where you're excited about it and want to do something. So in between patients, I'd have my computer turned to my, documents that I'd be writing. So somebody would turn up 5 minutes late or 10 minutes late. I'd quickly run down to the reception, block my time, unless there's an emergency, and then run back to the desk and write 10 lines or something like that. And that was over this period of time, probably a year or so, where we wrote a script, or I wrote a script that, so that all the 4 dental assistants and myself were all saying the same thing when we went to a talk at a kinder. Okay, so it wasn't a ad hoc, although it probably did look ad hoc when we actually did, because everyone presents differently, and every time you say it, it comes out differently. However, it was something that I could put the things together, give that to that person, and they felt that they had the confidence to be able to go and say the things. It had a few tips on getting there early and don't run out of petrol and all those silly things, drink water, those sorts of things that you might forget when you're really, really nervous. At the same time, we had the boxes on the right-hand side there. We had a little kit that had the posters and a few toys and things like that that you could take along to your kinder although they had a lot of their own stuff that a lot of the kinders do have an interest in those foods and things like that. So they had a lot of resources themselves, but if you turned up somewhere you didn't have them, you had them with you. In 2000 whilst I was doing these talks, the other assistants, dental assistants, were also speaking at various things, not only at supported playgroups and kinder groups, but at a children's expo, one of which is a Vietnamese expo, and she has the benefit of being a part of her community, and her skill of a second language is utilised at that expo. So 2004 brought, in partnership with another part of Southern Health, which is called Cardinia Casey Community Health Service, they gave me the opportunity to work one whole day as a health promotion practitioner, or health promotion, they call them champions. It's another one of those jargon words which just drive me mad, but anyway. So 1 day a week, so I'd go clinical, and then the 1 day a week I had this whole day to fill. And it was amazing. When I first started, I didn't know what to do with myself. And by the end of it, it was amazing how much we got done. We revised the further development of the kits. We planned with the health promotion practitioners the integrated health plan. We spoke at playgroups, anything from a group of, say, 6, like this group here, to a group where there's 35 parents. You can imagine how many kids there were. There's probably about 47 kids. It was like, I couldn't even hear myself over it, let alone get at whether or not there were people listening. And they were listening, but it was amazing. We put together show bags that we could distribute to these families. We had them also on sale at our clinics, Pakenham clinics, Cranbourne, Springvale, and Dandenong Children's at David Street. So there was lots of things going on. And there was another component of this work of organising and going to these sessions was being involved with a Doveton College. Doveton College is an innovative school where not only is there a primary school at the site, there's a secondary school, there's a preschool clinic, preschool, there is a set of offices that have maternal child health facilities, a refugee nurse, doctor. They all come in and book those rooms at various times, and the community can come and access them. So here I was, supporting the maternal and child health nurse during her open sessions, one day a week, one afternoon a week, and it was amazing. We unfortunately lost our funding just before we could start our screening program there. But it was amazing network. We were actually putting together these things of all these years. All of a sudden I was able to be doing what we had been talking about doing for so long. We were working with, there was no other dental person but me. There was all these groups that wanted to hear the message. And the message is still that simple: eat well, drink well, clean well. They still just wanted to hear it. So this was a really amazing opportunity to empower those families and those carers with that message and to advocate for children. Because there were times in that period of time, that's particularly at the end of that 6 months when the funding did run out, where I sort of thought, why am I putting myself out here like this? But it is for those kids that we keep giving that message. Monash Health has presented other opportunities to collaborate with sections of their organisation. Recently, in 2012, the Southern Health Climate Change Initiative invited us to work with them, where over the whole organisation we promoted water. So it makes sense. We've got the Drink Well message. So we held it during the ADA's Dental Health Week, and this is our waiting room at Cranbourne. Now, I probably had about 3 or 4 people working on this project in amongst their patients, and whilst they're doing their steri and all that sort of stuff, and they made posters. Like they actually cut and pasted, and it was awesome. It was a lot of fun. We got everyone working together. It wasn't my project or anything like that. This was from higher up. This is the organisation, who have nothing to do with just our little dental bit. They were asking us for our input and our work, and I just think that's what health promotion means. It's just that working together. The awareness campaign was basically on the tap water compared to using bottled water. And interestingly enough, we didn't really do much. We did promoting to our patients, and we asked all the little raindrops have answers from our kids and our parents of what their answers to the question, why is tap water better? They were great answers. But we had a survey of the staff, and really added an interest in the tea room conversations. I can tell you there was a lot of discussion about some of the environmental impacts that we found out through this initiative. Okay, so currently, as part of the Victorian Prevention Scheme, where all the health promotion money went. I think there's some enormous amount of dollars. They Healthy Together Greater Dandenong have me doing some training for them, and here I am doing my first PowerPoint presentation just recently. And we were talking with 33 maternal child health and kindergarten teachers. It was about a 45-minute training that we run through with the screening of the kinders that is coming up in June. I think the first one is 2 weeks' time. And at that screening there'll be a 2-hour session for actually doing the checkups, and there'll be also 1 hour to present to the parents and the children the messages. Now, what resources am I using? Well, the sugar display there was one that I made back in probably 2010, and now it's still being used, and it's being refined, but we're still using it. It just seems to be coming together. It's not a new thing, it's just, I suppose, a new direction for the funding, and that's where, it's been really amazing that it is actually coming together, that a whole project is doing all these little things that bit by bit have built up to. Currently there are 18 kinders that have taken up this prevention initiative, and I think 18, so that's 18 kinders we're going to, with nearly 1 or 2 of their sessions being screened over the next 6 months. I think health promotion really is about those connections as much as the messages we give, and one of those other catchphrases is partnerships, and there's lots of them. I've made lots of them during this time. Just a few up there. I've developed so many skills. I would not have thought that I'd be able to stand up here and not faint talking to you today. I can't believe that is the journey that I've been able to make. And yet I sort of know too, because really I think we're here to try to do our best to change this message or this image into this. And I think that is ultimately what it's all about. I really appreciate you listening, and don't worry, no questions.